Go ahead, doctor.
Okay. So thank you very much for your invitation to talk to this wonderful Congress. I would like to be there presently, but with vacancies and with holidays, it's not possible. And I hope one day I can come and share with you my knowledge on aesthetic and gynecologic rejuvenation. So you asked me to talk about botulinic toxin and the indication in gynecology. What doesn't work? Yes. What are we talking about? Botulinic toxin is the second most known non-surgical procedure. And we have to difference between aesthetics indication and pathology and rejuvenation indication, pain indication. And recently, it is also proposed as an alternative treatment in gynecology for pelvic pain, floor disorder, for vulvar pain, dyspareunia, and also vaginismus. So the history of botulinum toxin comes since the 18th century when there was, how to say it, a flaccid paralysis diagnosed by Kerner in the Napoleon War in the armies. So the pathogenic agent was identified by Everman Emengen in 1997. And so the time the first use in human was in 1979. It was because they saw that the toxin paralyzed the muscles, and it was used for strabismus, and it gets its approval from FDA in 1989. In 1992, we began using it for the riddles and for wrinkles of the face by Kurochers and his wife, and so on. You have new indication proposed in vaginismus, for example, by Brin in 1997, and vulvodynia, and in 2015 proposed for pain syndromes. Botulinum toxin is a protein complex. You have 7 types of toxin, but only types A and B are commercialized. And if you see here in the USA, you have Botox, which is Allergan brand. You have Xeomin, Merck Pharmaceuticals. You have Dysport. This is the 3 most known toxins sold in the world. You have some other toxins sold in Korea and in China, but it's not FDA approved. Mechanism of action of the toxin, it binds to the nerve terminals and it blocks the neurotransmitter release. So the nerve influx is not given to the muscle and the neuromuscular junction. You see, the toxin here is complex with some proteins which are called snare complex that does not form. So there's no transmission to the information on the other side of the neuromuscular junction, and the muscles are polarized. So the action is the acetylcholine inhibition at the neuromuscular junction because it blocks exocytosis. And you also have, so the principal effect is that you have a muscle relaxing effect. This is the widely used effect. But you also have other effects about antinociceptive effects because it have indirect, it also blocks other inflammatory and sensitization neurotransmitter. So it's quite efficient on a motor and sensitive way. The clinical effects of botulinum toxin are gradually taking hold and are evident after 1 week of injection, and the duration is about 3 to 6 months. As we said, BoNT is not a specific or cholinergic endings because, and so you have a wide spectrum of indication. It blocks also glutamate, aspartate, GABA, glycine, substance P. You have a lot of neuromediators that are blocked from their exocytosis are blocked, so they are not released. and they have effects. So what's up? We had a paper in 1915 about the botulinic toxin for neuropathic pain, who we passed from the motor, the muscle action to the sensitive action, because you have a myelinating effect, of course, but you also have a painkiller effect, peripheral and central nerve system effect. And that was widely shown by several studies. You see, for example, you have in 2018, a paper on botulinum toxin on pain syndromes for its painkiller effects. General recommendation, botulinum toxin is not a first-line treatment, because we have other first-line treatment as painkillers, other things to do when you identify the pathology, except few indication when you begin by botulinum toxin. Botulinum toxin is contraindicated during pregnancy if myasthenia or all muscle disorders, if there's a current amino acid treatment, hypersensitivity or allergy, and in the urinary retention, if you cannot self-void your autosondage, if you cannot void your bladder, it's not an indication. Generally, the side effects are very mild. It's well tolerated and have an acceptable safety depending on the injection site, depending on the indication. The effect is temporary, because toxin is degraded gradually, and so the lethal toxin dose is very high. It's about 40 units by kilo of body weight. So the lethal dose would say it's about 3,000. So it's very, very far from the normal therapeutic doses. There's large of safety margin in therapeutic and toxic dose. Preparation, you have it's a powder, because so you use a saline solution to mix it with powder. You have to mix gently the vial without shaking and slowly draw, and you have to use it immediately. But if, of course, if you have some remaining doses, you can still store it for 24 hours in the fridge, and you can use it during the day or in the morning. All the products are not the same doses. For example, 1 unit of Botox it corresponds to 1 unit of Xermin, but about 3 units of Disperse and 40 to 50 units of MyBlock. General indication, you have you had indication in ophthalmology, and after it was in neurology for trigeminal neuralgia, for migraine, in urology for stress in urinary incontinence, for overactive bladder, in dermatology for hyperhidrosis, for post-zoster pain, traumatology, you have a lot of indication, pathologic or aesthetic. But of course, it's widely used in aesthetic for face and neck wrinkles, for the visage, and for face sculpture. And in gynecology, as you have this sensitive, if anti-nociceptive effect, we begin use it as case report for pelvic floor disorder, for pain, and for vaginismus, as we're gonna discuss. So Time said in 2017, he proposed it as the drug that treats everything. You have here the different indications. And what about gynecology? First of all, I will talk about urinary indication. So the European Association of Urologists indication said it's a good indication of Botox as in urinary incontinence, but not in the first step of treatment. So you can use it on overactive bladder to paralyze the detrusor, to avoid this irregular contraction. You can also use it in ureter hypertonia, and even if it has no FDA approval for ureter hypertonia. But in the overactive bladder, it is approved, for example, in France. The complication is about the urinary retention. So you need to know how to self-void yourself if injected. Its administration mode is during a cystoscopy injection performance, and you inject in the detrusor. You had 10 to 20 points. Generally, you can do it on local anesthesia, and you use 50 to 100 units. And you see the activity of the bladder. Before Bounty, you have this irregular activity that makes you overactive bladder, and you have leakage of urine. And after Bonta, you have a release of this contraction. This was a paper in 2015 that gave FDA approval. Pelvic floor pain indication, you can use it. You see all the papers written on this. You have more than 40 papers now, and BONT can safely and tolerably be injected into a pelvic floor muscle in women as an outpatient procedure. This is very important as you don't always need hospitalization to do it. You can do it as an office procedure. Different indication: myofascial syndrome, piriformis, internal obturator, levator, ani, for treatment of neuropathic pains, pudendal neuralgia, and the cluneal nerve. But for this indication, you need electrostimulation probe. Why? To detect the location of the nerve. For example, for the piriformis muscular entrapment and the myofascial syndrome, you need electrostimulation probe that you can detect, and you can inject your botulinum toxin. For the internal obturator and for levator ani muscles, you can do it here. You use electrostimulating probe, but you can also do an office in gynecologic indication. You can also do an office injection without this electrostimulation probe. Anal indication, you also can use it as treatment for anal dysplasias or for anal fissure. Why do you have anal fissure? Because you have it complicates spastic hypertonia of the anal sphincter, and Botox is used as a good therapy to release that to treat that hypertonia. Specific gynecologic indication for vulvodynia, vestibulodynia, and vaginismus. This is the core of what is the vulvodynia? It's a pain of the vulva. You have essential vulvodynias, but you also have provoked vulvodynia. It's like dyspareunia. It's when you try to enter something or to have intercourse in the vestibula. So there's something which is painful. But here you have to look for any disease, for a very mild or very small lesion. For example, that when you touch that lesion, for example, or this lesion, when you touch it, you can have pain. And if you don't examine well your patient, you will say you have nothing, it's only in your mind, but not, it's in. There's a little lesion, you have to eliminate a little lesion. So vulvodynia, when there's no lesion, it's not a vulvar disease, neither an infection, nor hormonal disorder, nor atrophy, nor a drought, but it's a model of local hypersensitization. What happens? If you see, there was a paper that said that you have increased innervation of the vulvar vestibule during the, you have a lot of new innervation receptor that makes the vulva and the vestibule very sensitive. And how can you detect it? You use a Q-tip test to press and to see if you can provoke the pain just with your Q-tip test. because when you have this little lesion, when you have severe viral infection, when you have a little scar, lichen sclerosis, the menopause atrophy, when you have HPV infection, you have a sensibilization, and this hypersensibilization makes you a negative psychogenic reaction that contracts your levator ani, and it will aggravate and makes the pain more, make the situation more painful. What else? So you begin by a trigger actors. You have proliferation of vestibular nerve endings, and the pain comes to the central nervous system. And so ever you have a vicious circle between, it's just hypersensibilization. Just when you touch it, it goes to the cortex and it comes back with a pain, but even if there's no lesion. So the treatment, you have three treatments. You have the perineal axis, treatment of hypertonia. You can use kinesiotherapy, and you can use botulinum toxin here. You have the treatment of the hypersensitization of the vestibule for the application of lidocaine or specific cream. And you can use botulinum toxin for this indication. And of course, you can also treat with some brief therapy, cognitive therapy, and psychosomatic for treat the central, the cortex. Indication of toxin in the primary vestibulodynia, you have first of all to look for is there any lesion. Even it's very small, you have to look for it by a careful examination of the vulva and the vestibule. And sometimes when you have no lesion, you can say you can begin by hyaluronic acid. You can treat by PRP, but sometimes it doesn't work. And toxin is quite indicated to release the muscle and pain, the muscle hypertonia, with a part of the pain too. The hypertonia gives pain. What else I would say for vulvodynia, you can use it here with a little syringe and inject in 4 points in the vestibula, for example. You don't use too much doses, about 50 to 100 doses. And you have a lot of papers about good results after botulinum toxin in vulvodynia. It has good results and with 90% efficacy. What about vaginismus? Vaginismus, first of all, it's involuntary perineal muscle spasm without pain. Vaginism is a phobia of penetration. You're afraid of being hurt and having pain during intercourse. So the difference between the vaginismus is that the intercourse is desired but impossible because it's painful when you touch it. The difference between vulvodynia, that you have the intercourse is possible but it hurts. But so the vaginismus is a fear, it's a phobia, and you have different stages of vaginismus. One stage, the patient raises her legs and stops to prevent the penetration. So there's no pain, only the pain is only felt in a case of attempted penetration of rape, or if you rape the patient. So she doesn't let you inject, or she doesn't let you examine in severe cases of vaginismus. So first line treatment of vaginismus is behavioral therapy, kinesiotherapy, lubricant. What I do for vaginismus, I'll try to make the patient confident and to trust in me. We've taken a lot of time to explain what I'm gonna do. I try to enter a very thin dilator or my little finger, and I go bigger by bigger. So it's very important to take your time to explain not hurt and no hurry. You need to take your time. Sometimes it takes me 30 minutes to 1 hour of for consultation to explain the patient what is about vaginismus and to try to enter my finger. And I managed to do it in 90%. But after, when she goes out to home to have intercourse, the fear is still here. So you can indicate the buttocks when the perineal relaxation and sexotherapy support is not enough work to diminish his vaginismus. You have a lot of papers about botulinum toxin in vaginismus. The study that has the more patient is about Pelvic, who in a clinical trial engaged 241 patients and with injection of 100 units of Bantea. What you injected here in the vestibula and in the levator and in the pebble part of the levator only three points, you see, because if you go beyond that, you risk some complication. You may, if you inject too much in the sphincter, anal sphincter, you may have anal incontinence, and the action lasts for 6 months. So you cannot risk to have anal incontinence. There's another example for Brian Dick. He injected in the same places around the vestibula and 2 points in the levator ani and the pubovaginal bundle. Okay, 50 units each side. Pelvic has in his study, he says he has 97% efficacy for his patient, and it's very rare. But when you have adverse effects, you can have if the site injection is inappropriate, you can result in anal incontinence. Okay. So I'm going to finish. Pelvic plane in gynecology represent a frequent clinical entity. The diagnosis is often too late or delayed by the patient herself, who does not come to consultation quickly. And I would say that the botulinum toxin is a new approach to treat with his anti-nociceptive effects that can treat. You can use it in gynecologic pain too. And so thank you very much.
Thank you so much, doctor.
It was a little too long, I mean, maybe.
No, it was
how much time?
Suitable time. I think almost 30 minutes.
20?
30.
30. So you have
Okay.
this one, and I'm gonna shorten it when I will be live. You have this one, and
Okay.
And we'll be on. I'll be in live with you, and I'll try to shorten it. Maybe not to talk about. You have recorded. Can you send me the recording?
Yes, we can send you the video.
You can send me the video, and I'll see how to shorten it. Okay.
Okay, we can do that.